thought I can introduce Jenny Jo, who's a second-year Gastroenterology fellow originally from Atlanta. She received her BA at Northwestern University and returned to Atlanta for medical school at Emory University. She completed her internal medicine training and served as chief resident at Northwestern University. Her career interests lie in general GI and hepatology, as well as medical education. And she's going to take us through the controversies in acute management of acute colonic pseudo-obstruction. So, welcome.
Good morning, everyone. I'm back. So we're going to be talking about acute colonic pseudo-obstruction today. All right. I have unfortunately, no disclosures. And I'd like to welcome my expert panel. So thank you to Dr. David Greenwald, Dr. Nicholas Herter, and then Dr. Sue Han, who is coming in from Zoom land in the OR. Thank you for joining us.
Hi.
All right, so a roadmap for what we're going to talk about today. So we're going to start with the diagnosis of acute colonic pseudo-obstruction, where the current management guidelines are, and then delve into a discussion of neostigmine, endoscopic management, and then end on percutaneous cecostomy and surgical management. So what is acute colonic pseudo-obstruction other than a nightmare for the GI fellows on the consult service? So we refer to it more colloquially as Ogilvie syndrome. And this was first described in 1948 in patients who had neoplastic infiltration of the celiac and mesenteric autonomic plexus. And they presented with massive colonic dilation without an underlying mechanical obstruction. So there's really pretty sparse literature on Ogilvies in existence today. So we don't know the exact pathophysiology behind what's happening. But the hypothesis is that there is a decrease in parasympathetic activity from the sacral plexus, which results in colonic atony. We know medications play a role, so opioids definitely play a role. We know that there's some metabolic disturbances likely at play. And then there are also some other theories that hypoperfusion, lengthened hypoperfusion play a role, that there might be a role of prostaglandin E, and then there's even an infectious theory that reactivation of zoster may play a role as well. So this is a clinical and radiologic diagnosis. So patients are presenting with things like abdominal distension, pain, nausea, vomiting, constipation, and obstipation. And so we tend to see this population really only in our hospitalized patients. So what are the risk factors? So I wanted to refer to this one study. It's from 1986, and it's really like a hallmark study in Ogilvie's. It's referred to in literally every other paper that's ever been written on Ogilvie's. So this is from 1986, and they looked at 400 cases of Ogilvie syndrome, and these were patients who came in with nausea, vomiting, abdominal pain, constipation, diarrhea, and fever. And they were able to identify that 49% of cases were post-op patients. The two most common surgical procedures were C-sections and hip surgeries. And then they were also able to identify other risk factors, things like infection, underlying cardiac disease, and neurologic problems. So how do we diagnose Ogilvie's? So per the ASGE guidelines, abdominal activity is actually usually sufficient, but where it falls short is being able to completely rule out a mechanical obstruction. So barium enemas used to be standard of care, but we've really moved more towards CT, and that's because it has a sensitivity of 96% and a specificity of 93%. And it's great because you can both confirm the presence of colonic dilation and also be able to exclude intrinsic and extrinsic obstruction. So where are the guidelines right now? So ASGE guidelines has released guidelines in 2020. So they say if you present with acute colonic distension and you're able to rule out things like ischemia, perforation, or cecal modulus, those are all indications to go directly to surgery. You want to rule out a mechanical obstruction. And if you are able to do that, the first step that they recommend is conservative management in the first 48 to 72 hours. There's not a lot of data. There's no really randomized trials to support this. But basically, literature and anecdotal evidence has shown that conservative management is successful in maybe anywhere from 77 to 96% of patients. If you fail conservative management, they then recommend going to a trial of neostigmine. They don't specify the dose. They don't specify how many times you should try it. They say, give it a shot. If it works, great. If it doesn't, move on to colonoscopic decompression. They, again, don't specify how many times you should try this, if you're successful or not. And if you're not successful, they then recommend the last resort as being surgery or percutaneous endoscopic cecostomy. Interestingly, the European guidelines are quite different. So the European guidelines released at the same time, they recommend going straight to endoscopic decompression if conservative management fails. And they recommend skipping the neostigmine step. They also recommend prompt endoscopic decompression if the cecal diameter is greater than 12 centimeters and if the symptoms have been ongoing for more than 4 to 6 days. They recommend repeat endoscopic decompression. They don't specify how many times you should, but they do recommend trying it again. They also recommend placing a decompression tube into the right or the transverse colon after decompression because this helps prevent recurrence. They say don't prep your colon before you actually take them for decompression. And once you're able to decompress them, you should administer oral PEG solution to help prevent recurrence. And then finally, if you fail pharmacologic or endoscopic treatment, and if they're not a good surgical candidate, you should be considering percutaneous endoscopic colostomy or cecostomy in these patients. So I wanted to talk about this first step with the ASGE guidelines recommending neostigmine. So neostigmine is an acetylcholinesterase inhibitor. So it's reducing your degradation of acetylcholine and it's stimulating peristalsis. First described in the literature as successful treatment of Ogilvie's back in 1992. And the standard dose is considered 2 milligrams IV as a bolus over 3 to 5 minutes. There are only 2 main absolute contraindications to not being able to use neostigmine. That's intestinal or urinary obstruction and a known allergy or hypersensitivity reaction. I think where we get hung up are some of these more relative contraindications, so bradycardia, asthma, renal insufficiency, recent MI, and acidosis. The adverse events that we worry about, the 2 main ones that we get really concerned about are bradycardia and bronchospasm, but more common side effects are things like nausea, vomiting, hypersalivation, abdominal pain, and sweating. So if you're considering giving somebody neostigmine, you need to have them on telemetry, you need to have access to continuous respiratory monitoring, and you need to be able to access and administer atropine in the setting that they become bradycardic. So neostigmine is that first step after conservative management in the ASGE guidelines, and it's based on this data. So this is a meta-analysis from 2014, and they identified 4 RCTs with a total of 127 patients. And they found that neostigmine is actually really effective at resolving Ogilvie's with only 1 dose. So if they got 1 dose of neostigmine, 89.2% of them had successful resolution versus 14.8% who got placebo. The most common side effects that they reported were abdominal pain, drooling, vomiting, and bradycardia being this, really concerning side effect that we worry about really happened in a minimum number of patients, only 6.3%. And if they failed this first dose of Ogilvie's, they gave them a second dose and they saw a clinical response in anywhere from 40 to 100% of patients. Most studies looked at the subcutaneous injection, so a bolus dose, but they note that some of the studies have shown an improved response with a continuous infusion of neostigmine. And they were able to identify some risk factors for non-response. So things like male gender, younger age, post-surgical status, and electrolyte imbalances. So, in my very limited experience with Ogilvie's, it seems like we have a lot of apprehension with using neostigmine in clinical practice. And I think we get worried about a couple of things like perforation. Are we sure we ruled out a mechanical obstruction? Are they going to get bradycardic? Will they have respiratory side effects? And the need to sometimes escalate care in these patients to have close monitoring. So I found one study that was looking to address, the efficacy and safety of neostigmine in clinical practice. And what they found was that it's a retrospective study of 46 patients. They had 15 episodes of Ogilvie's that was treated with neostigmine initially. And after the first dose, there was a response rate of 60%, which went up to 87% after a second dose. They reported that there was really only 1 non-responder to neostigmine, and they ultimately went to colonoscopy. They failed colonoscopy, but they responded to a 3rd dose of neostigmine. And they report that there's only 1 case of transient asymptomatic bradycardia, which did respond appropriately to atropine. And they didn't report any of these dreaded complications of heart block, asystole, bronchospasm, or bowel perforation. So they went back and they talked to the providers and just tried to see what their hesitation was on administering neostigmine. And they cited concerns of mechanical obstruction, though this really should have been ruled out because they all had CT scans, and you really need to rule this out if you actually have a diagnosis of Ogilvie's. And there are incorrect assumptions that any kind of underlying cardiac disease, so things like AFib or heart failure, were absolute contraindications to neostigmine use. So the conclusion that they came to is that maybe we're just kind of too unfamiliar with neostigmine to feel comfortable prescribing this. So I wanted to turn to my panel, and I wanted to ask, Nick, do you think we are overly cautious in our use of neostigmine? Are we not?
I just wanted to.
Oh, okay, sorry. And do you think we should be using it more often, perhaps in our initial treatment of Ogilvie's?
So, unfortunately, I have like a Neostigmine horror story.
Oh, okay.
Perhaps the anti-Neostigmine
Okay.
side. And I've never read the ESGE guidelines, but I pretty much agree with all the ESGE guidelines.
Okay.
So my Neostigmine horror story is that in fellowship, I was involved in a case of a very frail old woman, as many of these patients are,
Yeah.
either post-op or they have cardiac disease, which is like contributing to the pathophysiology of the Ogilvies to begin with. And she had a bradycardic arrest from Neostigmine. So of course, that's my one in however many hundreds of patients that would ever happen to. But we will go further and talk about colonoscopic decompressions, but it's really easy to decompress someone. You can do it at the bedside and it's very low risk. And so I'm favor usually that. What do you think, Dave?
I have no Neostigmine. As I suspect if we went around, most people don't. So I would go back to, first of all, Ogilvie was a British surgeon, by the way. It wasn't an original paper, but I'd go back to the original data on conservative management, right? So conservative management, whatever that is, and I think that's really important, works in the published literature in what, 71 to 96% or something like that. So it mostly works. I think it has a lot to do with how you define when you start, calling somebody having pseudo-obstruction and then what happens after that to say, but by and large, I mean, I think doing what we do with electrolytes, fluids, proning patients, getting them to move around, to try to move gas around, getting up and out of bed, all the conservative things that we actually do, it works most of the time. So, your question is like, should we be going right to Neostigmine? So the Neostigmine data is pretty good, and it's pretty easy, and it works really fast, which is really nice, right? So if you haven't done it too much, I mean, this works in like 5 minutes when it works. And it works, as you showed, 70–80% of the time, right? So that's pretty good. I think the problem doing it is, at least here and at where I was before, is the logistics of it. It's not that we're really afraid of it. It's just a pain in the neck. You have to move the person to a monitored setting, which is not like easy, as all of you know. I think we would use it more if it were easier to do. But I think it has to be, we don't use it first line because conservative stuff works. The general approach to managing pseudo-obstruction, I think, has been to pray it gets better. It really is pray it gets better. So we don't have to do all these things. We're going to come back to endoscopic decompression, which I do think is a good way to go. And probably we should be less scared of that than we seem to be scared of Neostigmine.
Dr. Hahn, any thoughts?
So I do not have a Neostigmine horror story. In my experience, Neostigmine, as Dr. Greenwald alluded to, works very well, but it is not a first-line treatment. As Dr. Greenwald said, conservative management actually, for the most part, works very well. And then in terms of moving on to Neostigmine, yes, the kind of holdup would be transferring the patient to a monitored setting and having all the equipment available and in case they need to be intubated and so on and so forth. Dr. Greenspan just kind of alluded to another thing that I was going to say. In addition to atropine, you should have glycopyrrolate available to kind of counteract the autonomic effects of the Neostigmine as well. But from our standpoint, less is more in these patients. It's more of like a basic autonomic dysregulation issue. And so oftentimes the conservative management in the face of, these are very sick people. They're not without the comorbidities, and doing any kind of interventions stepwise sequentially has a higher risk of morbidity and mortality. So if the conservative stuff works, then stick with it. Just to be patient sometimes.
And Ari's right. Glycopyrrolate sitting in the ASG guidelines, I think, as a way to manage secretions.
All right. And Dave, how many times would you do a trial, or how many doses would you try Neostigmine before saying we give up?
Right. So again, going back to guidelines, and I'm big on guidelines because they do have the evidence at least synthesized for all of us. The guidelines would tell you that you should do a dose. It's going to work 70 to 90% of the time. There's going to be a recurrence 30 to 40% of the time. It can be treated with another dose of neostigmine, typically 24 hours later. That's typically what I would do. And that's the guidelines say to sort of stop there and move on to colonic decompression. At least the United States or the ASG guidelines say to do that. So that's kind of what I would do. 2 doses in 24 hours apart. There are some studies, I think you cited one of them, where they put the doses a little bit closer together. There's no real danger in doing that. So, you agree? Yeah.
All right, so moving on.
From our
to-
standpoint, sometimes we'll recommend maybe even doing it you can do it up to 3 hours later.
Yeah.
It does have a 90-minute washout period, but that's something that is in our guidelines that you could potentially do within three hours. If it's successful, you can repeat it as much as you really want without, any kind of side effects, or if there is sequential improvement.
Yeah, and the nice thing, like I said, it would work. When it works, you see it work. And the patient feels better, their abdomen goes down. You can take an x-ray if you want to show. That obstruction question you raised should never be an issue, right? And we have cross-sectional imaging. I mean, we know whether they're obstructed or not at this point. It's pretty easy. Colonic obstruction is not that common to begin with. Mechanical obstruction is not that common.
All right, so moving on to the next step in the algorithm, which is colonoscopy for endoscopic decompression. So this is first successfully described in 1977, and the literature really varies, but success rates have been reported up to 95% of patients. And there are some guidelines on how we should be doing endoscopic decompression. So using minimal CO2 insufflation, trying to avoid narcotics for sedation, should not be prepping these colons, and you should attempt to try to reach at least the distal transverse colon. And after you do a colonoscopy, you should be starting them on an oral PEG solution to help prevent recurrence. We'll get into decompression tubes a little bit later. But I wanted to mention here, the risk of spontaneous perforation in Ogilvie's is about 15 to 20%. And if you do perforate, your mortality risk associated with that is about 40 to 50%. So I think the conversation that we end up having as GI is, we get a little nervous performing colonoscopies in this patient population with the inherent risk of perforation already existing if they have Ogilvie's, added with the procedural risk of doing a colonoscopy in this patient population. And then part of the risk calculation gets a little muddy because oftentimes these patients need repeat colonoscopies because there's a 40% recurrence rate after the initial colonoscopic decompression. So where the ASGE and the ESGE guidelines differ is where should we be trying neostigmine or should we be going directly to endoscopic decompression? And that guidance is based on these 2 very small studies. So the study on the left is a 2016 retrospective study of 68 patients. These were patients who failed conservative management after 24 hours, and they either went to initial colonoscopy versus initial neostigmine, and they wanted to assess the treatment response. So in the group that got colonoscopy as their initial therapy had a response rate of 81.5%, and they didn't report any complications in this group. In the group that got neostigmine after failing conservative management, their response rate was 48.6%. So this is much lower than the previously reported guidelines that said, it's effective in 90% of patients. this is why we should give it a shot. They do note that this study did not try repeated dosing or continuous infusions of neostigmine. And they do have like a asterisk in here about who is actually doing the colonoscopies. They say it has to be an experienced endoscopist. They don't say exactly how that's defined, and they just say unqualified endoscopists are excluded from this study. So take that one. And so, as you can tell from the title on kind of where they fall on their recommendations, they say because of how much more effective a colonoscopy was, this should be used instead of neostigmine. And on the study on the right, this is a 2012 retrospective study of 77 patients. Half of them got colonoscopies and half of them got neostigmine. And what they found was that after 1 or 2 interventions of these, colonoscopy was significantly more successful than neostigmine, both after the first and the second intervention. A single colonoscopy was more effective from 1 or 2 administrations of neostigmine. Clinical response was better after colonoscopy, and cecal diameter was decreased significantly more after colonoscopy. There are some significant limitations to this study. It's very small numbers. It's retrospective, and there's actually ends up being a lot of crossover between the groups. So most of these patients actually end up getting both interventions at some point.
And their neostigmine numbers are lower than all the
Yeah.
other neostigmine numbers in the world.
Yeah. And then the European guidelines also differ because they have a guideline to say that people should be getting decompression tubes after colonoscopy, and it's based on these two very small studies. So the first study is a study of only 50 patients, and they report that if you put in an endoscopic decompression tube, there's an 80% success rate, which they defined as sustained decompression. It's most successful if you're able to put it into the right or the transverse colon. If you're only able to get it into the descending colon, it doesn't work. It doesn't do anything. They say try to keep it in place for like 1 to 3 days, but there's no good data about this, especially because spontaneous expulsion is really common, so it's hard to track how long they actually stay in. And then the second study is only a study of 20 patients. 11 out of 20 of them got decompression tubes. They reported 100% sustained decompression in them, whereas 5 out of the 9 had sustained decompression without a decompression tube. So, going back to our panel, where do you think, I think I know where Nick falls on that at this point. When do you think is the actual ideal time and scenario to take a patient for endoscopic decompression? Do you do the trial of neostigmine? How long do you wait for them to, respond to conservative management? And how do you assess their response to conservative management before going to colonoscopy?
I think Dave stated, basically the algorithm should be definitely, I think we all agree on this, definitely
Yeah.
trial of conservative management. Hard to define a cutoff, but I start to get more nervous based on the luminal diameter, which I think we'll also address.
Yeah.
After a certain threshold, I use usually around 12, then I might give up on conservative management earlier at that point, and then go straight to colonoscopic decompression. As far as doing the decompression, that data is interesting because it's definitely going to work. You just suck the air out.
Yeah.
It just might recur like an hour later. You don't really know.
Yeah.
So I think what you have to do is try to minimize the risk of the procedure, which you can do with a few things. The risks are going to be the anesthesia in these really frail, sick patients, and the risk of perforation with insufflation. So you can do it unsedated, depending on the patient's tolerance, or with like a little benzos and not using opiates, as you mentioned, because that could worsen the problem. And then either turn the CO2 off or low and just use water and try to get as far in as you can and suck everything out. You can do it bedside if they're in a unit that'll allow it. And I think it's pretty easy to do. And we'll talk about tubes too.
Yeah, so I would agree. Yeah, we'll come back to tubes and how to deal with the tubes. But I think that's exactly right. So I think not being scared of doing that colonoscopy is an important sort of point here. It's not, your points are great. The risk of perforation as the cecal wall thins and dilates is considerable, right? And so the issue there is that as the cecum is dilating and the wall's thin to begin with, it gets thinner, that deprives it of blood flow, it eventually becomes ischemic and eventually perforates, right? So, and we will come back to talk about the diameter of the cecum and the length of time, and actually think the length of time it's dilated is probably more important than the actual number that it's dilated. But when you start to see non-response to conservative measures, and then in my case neostigmine, then I would go to endoscopic decompression. I think we wait too long on all these things. I think we are afraid of all of this and we're still hoping it's going to get better. And I think when we get to 12 centimeters, 6 days, 4 to 6 days, we should be actively doing something. And the things are a trial, in my mind, a quick trial of neostigmine. If it works, terrific. If not, go straight to decompression. Nick's exactly right. Unsedated if you can, or minimal sedation. Water, CO2, low CO2. And then placing a tube in the transverse colon or beyond and keeping the tube there is the trick.
And when you talk to patients before you take them for colonoscopy in these settings, how do you counsel them on the actual risk of perforation? Do you talk about you're already at risk for perforating with your Ogilvies, and do you quote them any numbers when you take them for colonoscopy?
So you usually, you often can't talk to them because they're very sick, but you're talking to the family. I talk to them about the relative risk of the disease that they have, which is considerable in terms of perforation. And I think, a very minimal risk of perforation related to the procedure. Honestly, if they perforate during the procedure, you don't even know if they perforated because of the procedure or their ongoing disease. And we had a case earlier this year that probably was sort of somewhere in that mix where ultimately stuff was done, but perforation happened. We weren't quite sure how it happened. So did you have any comments?
No, I mean, in terms of our literature and our guidelines, again, with the tube, decompression tube, I mean, we recognize that there's no randomized controlled trials, but, these retrospective studies that you already mentioned showed some improvement. But in terms of endoscopic decompression, it does work very well, and the risk of perforation's quite low considering, how sick these people are and how large these could be. But exactly what you said.
But I think, Jenny, you want us to talk about whether we should be skipping the neostigmine step and going straight to this, right?
Or I guess should we be doing this earlier? Especially if I mean, we'll kind of get to the timeline and cecal diameter and everything. Okay. But do you think we are overestimating the risk of perforation in this population with just our colonoscopy? Because I think that's where we get really hung up. Like, are we going to do more harm than good by taking them for a decompression?
So I do. I think we're overestimating the risk. I think we are driven by fear of perforation, which is fair, but the risk of the disease here is really high. So we have an intervention that does work really well. It's actually not that hard. And all of us are qualified endoscopists. Like if you don't know how to drive a car and you get into an accident, it's sort of the same thing, right? Like unqualified drivers shouldn't be driving. I mean, you're all qualified to do colonoscopy. This is not difficult. I think we can do it. And I think we're afraid we're going to do something bad when we actually have the chance to do something good. So I'd be less afraid of this than most people are.
Yeah.
Sorry, just one quick question about, it seems like all of these are retrospective studies, right? There's none that sort of like randomize people to one versus the other.
That's what Jenny's going to do next.
Is there a thought that like all of these reports are just sort of it works really well because we're selecting these people that are healthy enough to tolerate these things.
Yeah.
And so I guess do the papers comment on that at all? Like, are we overestimating the success or underestimating the risks because already the people that got the treatment were candidates for it?
Yeah, I mean, and these are all, there's definitely selection bias that they can't quite get into, but it comes up in the surgical data too, like who's going to surgery, why does surgery have such high morbidity and mortality associated with it? Because we're only taking them to surgery once they're actually perfed and they're going to have high complications regardless. So there's definitely selection bias in all of these studies and they are all retrospective. Yeah.
Which goes back to my idea also about the conservative therapy working. It depends when you say like, this is when they have this, and they will get better in 3 or 4 days. I mean, if you define this.
Their 3 to 4 days.
Yeah, right.
How many days of consecutive prayer helps?
So I think Jenny, you're going to mention this, but
That's actually an
depending on
RCT.
if you're consulted today, the cecal diameter is already 13.
Correct. That's
Yeah,
what I meant.
that's usually what happens.
Change, are you going to give any days for conservative management, or are you going to jump straight to neo and decompression?
So, if you look at the guidelines, no, you're already ready to intervene at that point.
Yeah.
Even if they were on opioids and their electrolytes are deranged, then they haven't had a fair shot of conservative management.
I mean, you have to look at whether they have pain, whether they have any sign of systemic toxicity. I mean, you might give them a short window to see if they get better, but what's a short window? I mean, 12 hours,
Less
24
than a
hours?
day.
Yeah.
Less than a day, really. Because
Yeah.
it's hard to defend not doing something if you get, and that's usually when we get called. Like we don't get called at 9 centimeters, we get called at 12, 13, 14.
Yeah.
What about in these people who have a lot of dilation but are having some bowel movements already?
We'll kind of
But-
get into
okay.
cecal diameter, but you bring up an interesting point. It's like, when does the clock start and when does the clock reset? Is it like after you successfully decompress them, like do you go back to day 0, or is that like a timeline of symptoms? There's nothing clear on any of that. So this is gestalty at this point.
There's also like a couple of people on the chat. I've seen it pop
So
up.
the chats pop in and out
Oh,
here.
sorry.
So I don't know if anybody can see them.
Satish
is-
Satish is like really busy chatting.
Oh.
But I can't see any of it.
I'll be the voice. So Satish says anesthesia uses neostigmine all the time to reverse paralytics, and it's comical how afraid we are about giving it.
Right.
And then he also suspects that a lot of neostigmine failures have a bit to do with patient selection.
Correct.
Neo may work best for certain patients, we're just not sure who. And then Ari asks a question about adding glycopyrrolate.
Yeah.
There's some bronchial
We commented
data.
on that one
Okay.
while you were adjusting the camera.
Sorry, I was distracted. And then Ali thinks, we need to be careful about ensuring reassessment after conservative management so that we can move the care forward.
Yeah.
Correct.
Agreed. So kind of going on with this discussion, our biggest concern when it comes to Ogilvie's are ischemia and perforation. So again, the risk of inherent spontaneous perforation with Ogilvie's is 15 to 20%, and the mortality associated with that is 40 to 50% mortality. So the European guidelines quote a cutoff cecal diameter of 12 centimeters. So I was curious where this came from and how this actually correlates with our risk of perforation and ischemia. So it all comes down to this 1956 study, not great. These two guys, they took 100 healthy patients and they artificially descended their cecum with barium and air, and they looked at how big the transverse diameter of the cecum got in the prone position. Pretty bold. It's 1956, yeah. And so they found that the cecum would range anywhere in diameter from 3 to 10.5 centimeters, but the vast majority of the diameters were less than 9 centimeters. And then they looked at a population of 19 patients with colonic obstruction. Cecums ranged anywhere from 9 to 16 centimeters. They all perfed. 7 of them had perforations immediately. 12 had impending perforations, which I think means either like microperfs or evidence of ischemia. So that's how they got to this 9 centimeters as a critical point indicating impending perforation. And you'll see that quoted in some of these studies. But how do we get to 12 centimeters? Coming back to this kind of hallmark paper. And what they did was that they had these 400 patients, they did abdominal x-rays on all of them, and they looked at how big the cecal diameter was. And they found that there's a correlation with a larger cecal diameter with perforated or ischemic bowel. So they found that if your cecum was less than 12 centimeters, there were no perforations in this group. Granted, this is one study. It has not been replicated at any point, but the risk of perforation increased once you got up to 14 centimeters. So that's how you get to this like 12 centimeter cecal diameter cutoff as being, your higher risk population. So European guidelines, they not only recommend, looking at your cecal diameter, but also, like Dave is alluding to, the duration of your symptoms. So that's because, cecal diameter is not the only risk factor for perforation. These tend to be they're not high intraluminal pressure systems. And that's why your cecum can withstand being dilated up to 12 centimeters. But the risk of perforation increases the longer it's been going on. So they quote a study that says, if your symptoms have been going on for less than 4 days, the perforation risk was 15%. From 4 to 7, it goes up to 27. And after 7 days, it's astronomical. It's 73% risk of perforation. And they say that delay in decompression is actually associated with higher mortality. So going back to our panel, Dave, you mentioned this, but should we be relying more heavily on the duration of symptoms as a marker of severity rather than just doing, relying on repeat imaging and looking at the cecal diameter?
So symptoms are so the short answer is yes, but the symptoms are non-specific, right? So what's the symptom here? It's abdominal distension and bloating, it's some sort of discomfort, but as you all know, these people are very sick and they may have lots of reasons for some abdominal discomfort. So yes, we should be relying on duration of symptoms, but our best stuff is going to be evidence that you can point to. So repeat imaging, most of the guidelines suggest every 12 to 24 hours with at least abdominal x-rays. Sometimes a second CAT scan actually winds up helping. But I do think that once you get to, we'll say somewhere between 4 and 6 days, I'm moving more toward 4 days in my own sort of way of thinking about this, that we should be doing something very active. And again, comes back to an QI case that we presented on a similar topic earlier this year where nothing was done for a number of days. And I think as you go out more and more days, stable's not so great. Like stable at 12 centimeters, stable at 14 centimeters, not so great.
So basically all of the literature really quotes,
Sue has to leave in 10 minutes,
Oh,
so you
okay.
might want to jump ahead or something like that.
one question I did want to ask is, most of these studies are looking at pancolonic dilation and cecal diameter that gets dilated, but there is a group of patients that, it's not their entire colon, maybe it's more so just the left colon that's really dilated. Do you guys have a duration of symptoms or like a cutoff of other parts of the colon that helps you guide management in them? Or do you just view them as like a less severe variant of Ogilvie's?
I'm less worried on the left because the cecum is the thinnest wall and that's just more likely to perforate. As an aside, if they have dilation all the way down to the rectum, you can actually just get like a really big red rubber tube and put it in the rectum and decompress them and then you're done. So that's the easiest version of this.
All right. All right, so moving on.
Before,
Oh, yeah.
let's move on, but let's
Yeah.
also come back to the placement of decompression
Yes.
tubes and
Oh, yeah.
because we skipped over that somehow and I don't want to not do
Yeah.
that. So, but Sue's gonna want to talk about some of the surgical
Yes.
stuff. before she
Yes.
leaves.
All right, so percutaneous cecostomies, this is kind of the next step in the algorithm. They've been described in therapy, not just for colonic dilation in the setting of Ogilvie's, but also for colonic obstruction, cecal volvulus, and even pseudomembranous colitis. This can be done endoscopically, surgery, or through IR-guided methods. So it's thought that one of the advantages of endoscopic versus IR methods is that you can avoid general anesthesia. And I've included some images on how this ends up being placed, kind of like a direct access peg. And once they're able to be placed, they have a success rate of up to 100% because essentially you now just have this tube directly decompressing the right side of your colon. So you can leave it open to vent, but you can also use it to administer PEG as like an antegrade enema. There are pretty high complication rates associated with this, up to 40%, 42% of patients. So things like infection, bleeding, hematoma, perforation, buried bumper, and catheter displacement, so not insignificant. There's one systematic review that I found of 29 articles. They do report a pretty good technical success rate as well as a clinical success rate if you are able to place it. One kind of shady thing about the study is that they excluded major complications, so things like severe peritonitis and death. They just kind of said, meh, it's rare, let's not think about that. So they only looked at these other complications. So the most common complication is tube malfunction, followed by infection, pain, and bleeding. So the conclusion that they came to is that, you'll get durable symptom relief if you're able to place this with what they quote as low to negligible risk, which I don't know if I buy that. And they say one of the advantages of being able to do this via percutaneous methods versus a surgical cecostomy is that you can avoid stenosis of the stoma that ends up being formed. So Nick, I wanted to ask you, how many times would you repeat an endoscopic decompression before you would start thinking about percutaneous cecostomy in this population?
So if you're successful, it's definitely reasonable to repeat it at least once. I don't know if there's necessarily a number. It's kind of like how well they're responding, if things are progressively getting worse between your decompressions, how frequently they're requiring decompressions. I don't know if I've ever decompressed anyone more than twice.
Twice.
Probably give up after that.
Yeah, after two. There's no science behind this.
But I don't know if there's
Yeah.
any hard number.
Yeah.
Dr. Hahn, I was wondering, when you're having conversations with GI at this point, like what is your threshold to then take someone to surgery if they have not, they don't have evidence of ischemia, there's no perforation, what is your threshold to take someone to surgery at this point?
I mean, it really depends. A lot of these, as we've kind of discussed over and over again, these are really sick patients. And as you quoted, it's, surgery has double the morbidity, really high mortality. I think personally, the patients I've operated on for Ogilvie's, about half of them have died. So it's not something that's trivial, and it really requires a discussion with the patient and to consider undergoing the PEC tube, the percutaneous cecostomy tube, in lieu of surgery and see if that works, and usually it does. But also it's annoying because it's a tube that's sticking out of them, and who knows when to really remove it, and there's no real clear guidelines on that. And but in terms of surgery, I have to be very hard pressed if there's no obvious indications for immediate surgery, but it's something that is worth discussing, and patients have to understand the risks of the surgery.
So moving on to surgery, the current guidelines, the indications to take someone are if they have evidence of peritonitis, ischemia, or perforation, or per the algorithm, if you have thus failed conservative pharmacologic and repeat endoscopic management. Treatment options are things like surgical cecostomy, percutaneous cecostomy, or a subtotal colectomy. And like Dr. Hahn was saying, the mortality is extremely high. It's cited up to 44% in these patients. So I did run across an interesting article. Is there a cutoff cecal diameter to consider proceeding with upfront surgery, even if you don't have these indications like perforation or ischemia? So this was a very small study of only 71 patients. 21 of them got conservative treatment. 2/3 of them successfully respond, which is similar to the data that we quoted earlier, but 1/3 of them unsuccessful and ultimately needed either endoscopy or surgical management. In the group that got endoscopic treatment, 76% of them got colonoscopy and a decompression tube. Similar to other data, there's a 40% recurrence rate where they required a second colonoscopy, and ultimately 1/3 of them did require surgery, either because there was unsuccessful decompression, there's evidence of ischemia, or there was evidence of perforation. And then the group that went directly to surgery, these were for indications like acute abdomen perforation and sepsis. 80% of them did require operative decompression, 20% got some kind of resection, 12% of them had to go back to the OR due to ischemia. And the post-op complication rate is extremely high in this group. It's 84%, and their 90-day mortality was 21%. This study did try to identify risk factors for endoscopic failure. So they did a logistic regression, and they identified that colon diameter greater than 11 centimeters was the only factor that they could find to predict therapeutic failure of endoscopic treatment. And so because treatment failure is so common, 1/3 of the conservative treatment group, 1/3 of the endoscopic treatment group, they failed and they ultimately needed a different form of management. Should we be considering surgery earlier in this population, especially if their cecum is already, greater than 12 centimeters, and we've identified that as an independent risk factor for ultimately needing surgery? So that they argue that, maybe a cecal diameter of 11, 12 centimeters might be this cutoff, but they agree that taking a patient who's otherwise stable to surgery is a really hard conversation, especially given, our post-op complication rate's 84% and 90-day mortality is 21%. So I wanted to pose this to the group. Given this data, given that, 1/3 of this population may ultimately end up needing surgery, do you think that there is a cecal diameter at which point you think the risks of colonoscopy outweighs the benefits and you wouldn't do a trial of this before going to surgery? I suspect I know the answer, but yeah.
I don't think anyone's going up front to surgery
Yeah.
with those numbers, but
Yeah.
I don't know if Dr. Hahn has any other thoughts. The morbidity of surgery is just so high,
Yeah.
it's worth a shot. And even in that study,
Nope.
successful endoscopic treatment. So I think we would all agree not to go up front to surgery unless there's an obvious indication.
All right. And we've kind of touched on this, and there's no good data. It seems like anecdotally, nobody really does endoscopic decompression more than 1 or 2 times. But, if somebody has had a good response, do you think it's worth it to kind of continue to try with decompression tubes just to avoid surgery? Or is there an ideal number of times before you think this is going to recur often enough that they need some more definitive management?
I think this is sort of obvious, but it depends on why it's recurring.
Yeah.
If it's recurring because your decompression tube is failing, then you could keep trying it. If you keep, decompressing and take everything out and it keeps coming back, I'd say after 2, I kind of lose patience with this, but yeah. And more days are going by each day, each time you do this, another day or another half day or something has gone by. So, yeah.
Dr. Hahn, do you have anything?
Yeah, and there's also evidence that giving PEG for up to 24 hours after you have successful decompression kind of can decrease the chance of needing a repeat decompression. So that's something that would encourage.
Yeah, and I'm not sure we do that often. That's not something that gets talked about very much. Yeah, so it's a good thing. It's sitting right in ISG guidelines.
Yeah, it's actually in our guidelines that we recommend PEG for up to 24 hours after, just to ensure that there's decrease, because there's some data for it, and it's not going to necessarily hurt, since everyone's monitoring very closely serial X-rays and abdominal exams.
Right, and I don't think
I just want to say I do have to go, but thank you for having me. It's been a great talk.
Thank you.
Thank you.
I have a question about the PEG. So are you like, usually these patients have like an NG.
Yeah,
and
through the
it's not
injection.
like
Just
during
slowly.
glomerular suction actually. So then you kind of are trickling it down the NG tube over like, what, 2 liters over a day, or how slow do you go?
I don't know that there's guidance on this.
Yeah. Okay,
We're probably not accomplishing much with NG suction. We just do it
That's
maybe
right.
it makes the abdominal distension a little
Yeah.
subjectively better. It's probably not decompressing the colon anyways.
yeah.
Yeah, and there's some evidence that you don't need that much of the PEG solution. So one of the guidelines suggests it's essentially 2 capfuls of PEG solution. So it's not like a full colonoscopy, perhaps actually less. Although I don't know that information rigorously, so I'd have to look back to see the actual dose.
ASGE and ESG don't have a specific dose or
Right.
anything that they recommend. Yeah, and
Uh,
most of the studies don't include follow up with PEG. At
Right.
least the ones that I
Which is why I think we don't use it that
Yeah.
often. But it's worth looking into. Then maybe it should be the way to go.
as tolerated.
All right, whatever that.
All right.
What decompression tubes are you using? Because
Let's come back to
Okay.
the tubes for a
Yeah.
minute.
The
How
one
do you put a tube?
Actually, I don't know the one we had. The one I used is a 14 French Cook tube. Is that
Right.
the one we have?
well, so because the reason I asked is because Salama had a case last year on service where we decompressed this lady in a TICU like twice, and then we asked them for a tube, but it was one of those that only goes up like what, 30 or 40 centimeters, like
Yeah.
not very long.
Yeah.
And there's like a rectal balloon that gets inflated, so you're limited by the length that you can get up proximal to it.
So there is a long, it's like 100+ centimeters.
How do we
14
have that?
French white tube. I don't
Yeah.
know.
Yeah.
It looks exactly.
Yes.
Abby and I use.
I just used it,
Confirmed.
but then I didn't know what to attach to the end of it.
Yeah, this is open.
Yeah, you have to MacGyver it.
You have to MacGyver.
Yeah.
I added like a Foley
Yep,
Yeah.
thing to it.
that's perfect.
Okay.
So there's 2 ways to place it. I would say
Right way in
that.
the wrong way?
No, I don't know. There's like the attach a suture and drag it way, which I would say is probably the easiest way. And then it comes with a wire and you could do it over a wire. But if you don't have fluoro and you're not experienced exchanging wires, it's probably not worth it to mess around with the wire. But it comes as a tube, there's an inner catheter and there's a wire. Pretty much, I would say throw out the wire, tie a suture like a silk air knot to the end, grab it with like a hot biopsy forceps, and then just drag it alongside the scope as far, ideally into the cecum, as far as you can get, and then tape it externally. You have to MacGyver some sort of connection to a drainage bag to gravity, and it'll fall out guaranteed within like 48 hours.
But isn't the issue that it comes back? You know,
When you pull the
even
scope
if-
out.
So
That's
a little
part of
bit
the issue. It's
of
not
what helps
dragging.
is the that guide catheter inside the inner catheter. It makes it a little more stiff, so you can kind of try to put back pressure and wiggle jiggle your scope out. But yeah, you do pull it back a little bit.
You ever clip it, like PEG style?
Oh yeah, you could also carry the suture with a clip and then deploy the clip in the colon. But depending on if the mucosa looks good, clipping ischemia. But yeah,
This may be a dumb question, but if you are collecting it, like hooking it up to a drainage bag that's another like blind end, like are you really decompressing or are you just sort of creating like a larger lumen for like you have to like
Yeah.
how often you like someone has to like
Yeah,
regularly
yeah.
like drain the bag and
Well,
everything.
otherwise it's just like an open poop hole.
Yeah.
But I mean, you put it up, I mean,
Maybe
the anus is sort of that anyway.
yeah, they have to stay on top of it. But it usually doesn't like. I
Yeah.
don't know. I've never seen the drainage bag
And-
now.
Do you usually cut additional fenestrations in there just because it's gonna get clogged with the draining stool and
The
everything?
proper
or-
one has a million side holes.
Okay.
There are, if you are MacGyvering one,
Yeah.
you might have to cut holes. When I was mentioning the little red rubber, which is really
Yeah.
only for rectal decompression, kind of similar to what maybe you had gotten, that's designed as a Foley, so it only has one hole at the tip,
Got
and
it.
you have to cut out little side holes.
Got it.
So
Okay.
it doesn't get.
In the endoscopy suite, there is a decompression tube. It's white.
Yeah.
It has a wire in the middle of it. I've actually done it in the past with threading the wire through. So the endoscope, you're supposed to get past the splenic flexure. So how do you know you're past the splenic flexure? Like, you hope you're past the splenic flexure. You can do it with fluoro. That's probably the best way to do it if you have it available. So think ahead. I think having fluoro available is great. Once you're past there, as far as you can go, is correct. I pass the wire through the endoscope, pull the endoscope out and thread that white thing over the wire. There are a zillion problems with that, but again, if you have fluoro available, it's really a good way to go. And then once you've gotten to where you want to go, you pull the wire back out, and then I usually I tape that white thing to the rectum and pray for the best, and I leave it open because that's, to your point, that's what you want to do, is drain it out. The nurses don't like that. The stuff is coming out, but that's what you're supposed to do. If you attach it to a Foley bag, you have to open the Foley bag periodically to drain everything out, otherwise you're not actually doing anything. And then repeat x-rays to see whether the tube is still in the right place, unless it completely falls out, which it usually does. We do not have a better system than that. Right now, I like the dragging it up with the clip at the end. Yeah.
I also have a very stupid question.
Oh.
Oh, sorry.
I was just gonna say I used the white tube as well, and someone who maybe is not as experienced was able to do it. So it is capable of doing, and it worked. Eventually, it coiled up at the bottom, but for 2 days or so, it drained. So it's possible.
I have a really stupid question. I never quite understood why the cecum can dilate so much, and yet the ileocecal valve is right there. Why doesn't that just open up and decompress? Does it make any sense to put a stent in the ileocecal valve? As a new indication for lambs or something like that. Does it make any sense? I mean, it'll probably migrate, but if it stays there for a day, I mean, it's probably no worse than a decompression tube that falls out in 6 hours. I don't know.
Could be. It'll be for Jenny's study, because Jenny's going to propose the study. The next slide is Jenny's study.
No.
Question, but in theory, I would say no, because in order, so number one, the catheter length for the stent is not long enough to go through a colonoscope.
Oh.
So it would require you to have to actually deploy the stent out of the catheter and then backload it through a colonoscope, and then you have to like push it out into the ileum across the valve. It's just
what could possibly go wrong.
Yeah, exactly. It's just not for a number of reasons. It's just not a.
So it technically can't happen.
Yeah, but also I think because if you think about even just like a standard colonoscopy, when you're trying to get into the TI, and I teach this fellows, and I'm just going with them. If you have a lot of distension of the cecum, it closes down that valve.
Yeah.
So even standard colonoscopy, you suction down the cecum a little bit, and that releases some of the the pressure that's closing the valve. So I think that's probably why even a competent IC valve, it's going to just get closed because of the pressure.
Right, but if we forced it open with the stent.
You force it open, yeah, but it's just not, for a number of reasons, just technically not going to be feasible or helpful there.
Something for Boston Scientific to work on. Okay.
We need a new stent.
All right, so in the last couple of minutes, I wanted to propose a new algorithm because, it doesn't sound like the ASG guidelines are, I know this is a nightmare for the fellows that hate me for this, sorry. So kind of proposing, risk stratifying these patients perhaps into like a higher risk and a lower risk group, using both cecal diameter as well as the duration of symptoms to kind of help prompt us into, I guess, faster management of these patients. If you haven't had, I guess, a neostigmine nightmare story, perhaps trying this a little bit earlier. If you failed conservative management, maybe moving up that 72-hour mark a little bit earlier and trialing a quick dose of neostigmine, since we will see a response relatively quickly, and seeing if that works. And then I think my big takeaway from this is moving to endoscopic decompression and being a little bit less scared of that as a procedure to do in this patient. And I think we can do a lot of good by doing that. And once we do the endoscopic decompression, placing a decompression tube and being sure to administer oral PEG solution for them to try to help prevent recurrence in them. I think getting surgery on board early as part of a group discussion, multidisciplinary discussion, is a good thing. And then also with our advanced colleagues thinking about, whether or not, if these are failed interventions, thinking about when to then pursue percutaneous endoscopic cecostomy or surgical evaluation. So the main takeaways I have are that neostigmine may be an effective treatment, might be underutilized due to perhaps overblown concerns of adverse events. Endoscopic decompression might be a more effective therapeutic option than neostigmine, with better clinical response and more sustained response. And though there is a risk of perforation associated with endoscopic management, we really need to balance this with the inherent risk of spontaneous perforation that already exists in Ogilvie's. And then we need to consider both cecal diameter as well as the duration of symptoms when making decisions about treatment. And I think there might be indications to consider going straight to endoscopy, perhaps not for surgery, rather than, doing a prolonged trial of conservative management and kind of praying for the best. And with that, that's it. That's all I got. Happy to take any questions.
Hey, Jane, that was fantastic. I wanted to share a couple of points. One thing, I think Sue brought this up at our previous conference. The proximal 2/3 of the colon, that's actually innervated by the vagus nerve, and the lower third of the colon is done by the pelvic nerves. So sometimes you get some differential manifestations of this where it's only the proximal colon that's dilated. And I never understood that until Sue mentioned this, because why isn't it always just the whole colon? I think it's just due to the sort of different innervations of the colon. Because that's one area that comes up, is sort of like the left colon is decompressed, the proximal colon is dilated, and that's why. It's because of where the vagus nerve is located. The other thing is, if you think about this disease as an imbalance of parasympathetic and sympathetic nervous systems, that's where Neo does make a lot of sense. So one thing that I like doing if we have to do a colonoscopic decompression is to give Neo in endo, right? Go up to as far as you can, suck out the air, but you haven't done a whole lot to get a good parasympathetic surge. So once you come out with the scope, have the anesthesiologist give Neo, because again, they give Neo all the time, but they could care less. And I've seen patients completely decompress on the endo table. And I think that's where PEG comes into play, because now you've got this, high osmotic load in the colon, which then forces more contraction. And so it makes sense that it might help reduce recurrence that way.
If you give Neo an endo though, and there's a 90-minute washout period, do they
Just leave them in recovery.
They're monitored.
They're all monitored.
Better than they are on the floor.
in our
Yeah.
endo unit?
Yeah.
Okay.
And you don't need to watch them for that long
You don't
afterwards.
need to watch them. You don't need to watch them afterwards, right? It's
I
just
don't-
while
I
they're
don't
getting,
know.
no, it's while they're getting.
Just
the-
like in the
yeah.
moment of
Yeah,
administration.
I think it's in that first 3 to 5 minutes is if you're gonna see bradycardia, it's gonna be immediately, you'll see it.
And I think Mark Corsten used to always give glycopyrrolate, if I'm not
Right.
mistaken. That's what Ari was talking about. Would they do that too, you think? or-
Yeah.
They give that all.
They give that all the
Yeah.
time.
It's like at the ready.
They give
So-
people, they give
Yeah.
people atropine all the time too.
Yeah.
I mean, they give a lot of stuff.
They're prepared to handle
Yeah.
anything that
I
happens.
go help with the
also.
bradycardia.
Has anyone done a PEC?
No.
No.
I would I saw the pictures of endoscopic cecostomy. That sounds crazy to me, because you already have an insufflated lumen, then you're putting in more
Yeah.
gas or air to get it.
It's more common by IR, but
Yeah,
very,
I
very
would
The IR people do it for us.
Yeah.
The downside,
What's the one-to-one look like?
There's a lot of it described in the pediatric literature is what I saw, less so in adults.
I was also struck in the stuff that you sent about the incidents with C-sections.
Oh, yeah.
I mean, I don't know, do we see a lot of people with?
I've never gotten.
I've never
that.
had
Yeah,
this when I was
these
a
are
pregnant
all
patient,
older
and
people, it's never
I hope
people
to
who had
never
C-sections.
see it.
Yeah.
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 I also wonder about the sort of, with the PEC, it's like, when do you take it out? Is there gonna be a colocutaneous fistula?
Yeah.
You know,
I had a patient who we put a cecostomy tube in, IR placed it, and we kept it for a month, and we removed it, and she survived for many years. She was my intern, first year fellow patient, so I saw her many times until I left Sloan, and she had a colocutaneous fistula,
Yeah.
and turned into an ostomy situation.
Yeah.
We couldn't close it.
the other thing is, I sometimes feel like we rely too much on serial imaging. You just have to examine these patients. You get one set of imaging, a big colon. Okay, you're not looking for, is it 12, now 11 centimeters? You're looking for that belly to no longer be tense.
It has to do with the number of